Thank you. Welcome, everyone. This is another session of on MS and COVID-19. These sessions are organized by the International Women in MS Network. I'm Fabienne Brilot. I'm from Belgium originally, but I'm based in Sydney, Australia. So good morning to all. We are about to start with our first speaker, who is David Baker from London, UK.
Okay, so good afternoon, morning and evening, everybody. So what I want to do is try and give you my take on COVID-19 and how it relates to MS treatments. So here are my disclosures. So what I want to do is really talk about, obviously, how do MS drugs work? And therefore, we then need to also then think about what is the immunopathology of COVID-19? And then also ask the question, how does the immune system get rid of the SARS-CoV-2 virus? And in doing so, it will give us what is the relative risk for the different MS drugs for COVID-19. So virtually everything I'm going to say today is in this review, which you can read and critique at your leisure. And I will say that many of the bits of information were taken from bioRxiv. So obviously it's not been peer reviewed, but I tried to get 3 or more confirmations to show us what was going on. So if you think about multiple sclerosis, you ask the question, what are the dominant cells in driving the relapsing disease? And if you've been following me for any time, you will understand that I believe that the memory B cell is a central player in driving MS, and all MS drugs inhibit memory B cell function, and the ones that do it well work the best. Now, you can argue that could be a direct effect, or it could be downstream or upstream of an effect via CD4 cells. Now, the question is what occurs with the COVID-19. So if we look in the pathology, it seems that there are kind of a few natural killer cells, and granulocytes aren't particularly common, except there are neutrophils, and this is quite often where there is like a secondary infection. So otherwise, it's, there are quite few of them. So that then leaves the plasma cell, the CD8s, and the macrophages. And what I want to try and convince you or suggest to you is that actually the antibody response may come up after the virus has been removed, suggesting that the B cells aren't quite as important as we think. So that then leaves us with the CD8 and the macrophage, which of course we know are the central players in the progressive MS lesion, and we know that our drugs don't particularly target it very well. So what I want to really focus on is really the macrophage, because I think that's the central player that we need to be dealing with in terms of our immune system. And that's what probably is the first line of defense against the virus. So about 80% of people are asymptomatic. So what happens? And we can go to animal models to give us some clues. And what we can see in these monkeys that were infected is that there is immunity within 3 to 5 days, clearing the virus. And then if you give a re-challenge, you get protective immunity. Now, the interesting thing is when you look at the antibody response in these individuals, it doesn't really occur for 2 to 3 weeks, yet the virus is cleared within less than 10 days. So there's a disconnect. And that's also true of when we look at the a mouse with human ACE2, and you can see that the virus is cleared within 3 to 5 days. But if you look in the lungs of the mice, there's mononuclear cell infiltrate. There are very, very few B cells, very, very few T cells, and the macrophage is much more dominant. So what happens in humans? So you've seen this individual coming into Australia. There's a pre-symptomatic period, the median of about 5 days. This individual clearly got an immune response within 4 to 7 days and cleared the virus. But if you then ask the question, when does the antibody response appear? Again, it seems to peak after the virus has been cleared. So if you look in that individual, again, you look at the antibody forming cells, again, they are accumulating after the virus has been cleared. There's a CD8 T cell response at that time point. And importantly, if you look at the individual, you can see there's a big drop in the monocytes. Now, I think that's important because there was a few individuals that have had cancer, and they had like their lungs removed, and then they found that actually they had COVID-19. And when you look in those lesions, you can see actually it's largely macrophages, although you can see a few granulocytes. There's probably an eosinophil there. So that suggests that one of the first parts of the immune response is actually driven by macrophages. And then the animals tell us that the CD8s are quite important. Now, the macrophages are also the central player in terms of what is the severe pathology. And this is also seen in a number of different studies. So here is an example where you see the macrophages in the lung. There are very, very few B cells. There are very few T cells. And the T cells that are present, it's interesting that it tends to be CD4, and there's a real paucity of CD8s, suggesting that maybe there's a senescence in the CD8s, which possibly allows the macrophage response to go a bit crazy and obviously contribute to the lung problems. So here's my current take on the SARS-CoV. So we have the virus infecting the pneumocytes, creating problems in the lungs. The first line of defense is the macrophages and the innate immune system. And remember, most of our MS drugs don't particularly target that. Then we have the adaptive arm coming in, particularly the CD8s. This is kind of a bit hypothetical. And then a bit later on, the viral response comes in and clears the virus in the vast majority of people. It seems that there are viral escape mechanisms that allow the virus to escape, and that causes the lymphoid tissue to become decimated, and so that contributes to the lymphopenia that we see. That is then associated with a inflammation of the macrophages going into the lungs, creating the acute respiratory distress syndrome, and then hypoxia. So that is the basis of what the review was. Now, if I were to write this review this week, I would actually be really focusing on the endothelial cell, because I think this is becoming a central player in what causes the respiratory distress. And we also need to consider the angiotensin renin system. And obviously that's linked into the virus targeting the ACE2 receptor. And that blocks some efficacy, creating an environment that actually creates oxidative stress, and I'll come on to that. That then links to the coagulation system that causes thrombosis, and that's a central problem occurring in COVID-19. So we have the lung issue that's driving some of the ARDS and the respiratory problems, but we also have a vascular coagulopathy, which is developing. And you may not be able to see this, but this is just a blood vessel, just to say that the ACE2 receptor can be expressed on the blood vessel. And then we have the von Willebrand factor, which is within the vasculature. We have the angiotensin system, and basically we get angiotensin 2. And in the presence of ACE2, it creates angiotensin 1,7, which is antioxidant. And this is also associated with vasodilation. But what happens with the virus, it blocks the ACE2, and so it blocks the angiotensin 1,7, leading to constriction and potentially pulmonary edema, and creates free radicals. And that may be augmented by peripheral blood neutrophilia. And that causes damage to the endothelia, which then releases von Willebrand factor into the blood. This causes clotting, and that causes thrombosis. So that it perhaps is a central pathology. And we ask the question is, what do MS drugs do to this system? And the answer is probably very little. So what happens to the neutrophils? Well, again, most drugs don't target the neutrophil. The tissue macrophages, most MS drugs will not target the tissue macrophages. The monocytes, well, there's a transient effect with alemtuzumab. My concern perhaps would be with actually natalizumab, because VCAM is expressed in an inflamed lung, and perhaps that could stop the monocytes getting into the lung tissue. Now, if that's a problem for the severe disease, then obviously these agents would also protect against that. And this issue may be limited by the extended dosing interval, because that may allow the macrophages back into the tissues. What happens to the CD8s? Well, we know that there's a long-term depletion with the alemtuzumab. Again, the issue with natalizumab is potential. Fingolimod causes potential lymphopenia in the naive cells, and dimethyl fumarate causes lymphopenia in about 20% of cases. Cladribine is an interesting one because that's kind of linked to the same type of severity potential as alemtuzumab, yet actually CD8s generally remain within the lower limit of normal. Plasma cells, well, most of the agents probably don't target the plasma cells because they don't express CD20 limited CD52 and not much of the DCK. My concern perhaps would be the immature cells, because with ocrelizumab you may damage those, and it may then impede your effect to have a vaccination. So taking that all together, actually what I would potentially suggest, and this idea was made before I knew any of the data, is that maybe actually people with MS may respond actually much more similar to the general population than we would first have thought, but time will tell. And I have to thank the iWiMS group, because you've really kept us really well informed. So thank you for listening, and I'll take any questions later on. Thanks.
Thank you very much, David, for these very informative and clear presentations. We will, if you do have questions, please post them on the chat and we will come back to them later. So our next speaker is Nick Riker. Right? Nick, are you in the call? Yes. Sorry for the pronunciation.
That's okay.
Remember, it's early morning for me.
I think somebody needs to
David, could you
share?
sharing
David, presumably.
Thank you.
It's always a pleasure to follow David. So thank you, following David, really thank you to iWiMS for hosting all of these calls, and especially for asking me to join you. There's lots of other people that I should be thanking. There's so many people involved in this data sharing initiative, but to start doing that would take a load of time, and I don't have a load of time. So I will just thank Lisbeth Peters, who's very much my colleague in this whole endeavour and is responsible for a lot more of the work than I am. But I'll talk you through some slides, and I'm sorry there are more than two, but I'll try not to take too long. Can you see the slides?
Yes.
Yeah. Okay, so this represents how the data is coming together, how we're really collecting. And as we've said before, the bulk of the data is actually being collected through existing registries and cohorts around the world. There's a little bit of data which is being entered directly into the Qmenta platform that's hosting all of the data. That's for people, either patient reported or clinicians that don't have access to registers or don't for some reason wish to use a register. But the bulk of the data, as I say, is coming through existing registries. Some of that, as we said previously, is being transferred into the data platform, so we can then explore and analyze that data. But it's really hard for some registers, some of the biggest ones, to transfer their data. So, but they really wanted to collaborate. So what we've done for those is to enable them to be part of this program, to share their data in a different way through running queries locally in their own platforms and then sharing the results. So that's enabled us to start to build a bigger data set, which is what we really need. But you'll see as I go through that we really do need more data. So what I'm showing you today is a long way from results. It's very much still in the exploratory phase. So we separate out clinician and patient reported. We always felt it was important to have both because our anticipation was that clinician reported would be more inclined to the more severe COVID disease, and the patient reported would be much more inclined to the mild disease for fairly obvious reasons. And for the clinician reported, we've then taken them simply as reported by clinicians as either confirmed or suspected cases. For the patient reported, at this stage, we're applying extra rigor to that. So we define them not only whether a patient has said they suspect they have COVID-19, but we apply an extra layer of whether or not they exhibit particular symptoms, and they've recorded those symptoms. And there is even a layer in addition to that for people, because in some registers they don't ask for suspicion. So we had an extra way of defining as suspected for patient reported with additional symptoms. So that's very strict. So we have a lot of patient reported data, but applying that quite a strict extra layer of definition reduces the number down quite considerably, which is why it's only then 250 are confirmed and suspected under those definitions, whereas the clinician reported remains at 374. Now those are still quite good numbers, but as you'll see as I go through that it's still not enough. So what we've asked ourselves is, from the data we've got so far, is it starting to give us data which we would expect to see? Because that's really critical for us to have confidence in the data. And so far it is. So if we think about the known risk factors, age is clearly a really obvious one. And then we look at whether people are more likely to be hospitalized when they go up the age range, more likely to be in the more severe outcomes of ventilation or ICU. And as this diagram shows, particularly for the clinician reported, the age correlation for ICU is very strong. It's not as strong for hospitalization, but it's still present. And the patient reported here is rather noisier, but there is still the association with greater age. So that's reassuring in terms of what the data shows. The same is true of, if we look at EDSS, if we were to say patients greater than EDSS of 6, we would expect to be much more likely to be hospitalized. And that's true in this data for both clinician and patient reported. And we'd expect people with progressive MS more likely to be hospitalized. And again, that's true in the data that we have. So then the really critical question around association of more severe disease outcomes with any particular treatment, obviously that's much harder to build really powerful data on, and that's what we're endeavoring to do. But the truth is we're not there yet because we don't have the data we need. But this table attempts to at least show a bit of what we have now. And so on the left is the total number of people for the variety of treatments. I should point out that this is still a little noisy. We have a lot more analysis to do and data cleaning to do. In the missing category includes people who are not on treatment, never treated, or in some cases other treatment, which they may have defined. But it will be useful, particularly as we get more data. And if you compare the total people on those treatments and the percentage chance of them being on that treatment compared to the percentage chance of them being hospitalized, there are quite large differences. And in this case, that would at least point towards rituximab, ocrelizumab in the clinician data, and at least towards those, but also dimethyl fumarate in the patient data. But I would stress absolutely that it's too early to draw conclusions from. It's very exploratory, and we need more data to reach firmer conclusions. And we also need to be able to remove some of the noise. And what we'd really like to be able to do is to then adjust these results for clear risk factors like age. But of course, the more risk factors we want to adjust the results for, the more data we're going to need for that to make sense. So that I would say also that we do have by treatment all of the data you'd expect us to have on the more severe outcomes of things like ventilation and ICU, but the numbers for that are so small that we didn't think it was sensible to present that to you today. So I hope you've had some insight into what we'll be able to do through pooling data. The systems that we've built are absolutely working. So I hope I can encourage people, if they haven't shared already, please do, either by the route of transferring data or by the alternative route of running our queries locally and then sharing your results. But we're getting there bit by bit.
Thank you, Nick. At the moment, there is no question in the chat, so we're going to continue with the next presenter. Jan Illet from Sweden is the next. Jan, are you there?
I'm here, yes.
Yes.
May I share my screen?
Yes. So are you using your presentation? Yes.
Yes, I'll try to do that to see if I get it to work. So do you see my slideshow now?
Yes.
Okay, so I'm happy to provide some early data from the Swedish MS registry. And this is a clinical MS registry, which is fairly unique in having a high population coverage. We have some 85% of prevalent patients in the country in the registry. And that gives us the chance to review data on MS patients with COVID in the population-based setting. And these are then again very early data. I would like to emphasize that again. These are very preliminary. Numbers are still small, but this is, to my belief, something that it shows something that could develop into a pattern, and therefore I would call upon great participation in the MS COVID data sharing that Nick just described, because we certainly need more data. And maybe there is something here. So this is the overall results. We have so far no more than 65 MS patients with COVID out of the 17,000 patients in the registry. Those identified with the COVID are slightly younger than patients in the full population. Those hospitalized are a bit older, those in ICU a little bit as well. The female to male ratio seems to be very much the same. There are slightly more progressive patients among the more severely affected. The same goes for EDSS. Disability is higher among those more severely affected, reflected by hospitalization and ICU. When it comes to DMTs, overall, not much of an effect, I think. But what really sticks out here as something possible is that we have some 50 or 60% of rituximab treated patients in the registry that are hospitalized, that are in ICUs, compared to a proportion of 33% of the population. And then, of course, Sweden sticks out as a very peculiar treatment pattern country in having a third of the prevalent patients on anti-CD20 treatment. But even so, this is like almost twice the number compared to the background population here. And this of course, warrants us to look more closely into this. And the question then is this because people on rituximab are older? Are they possibly more disabled? Well, no, they're not. They're actually slightly younger compared to the full population in the registry, and they are slightly less disabled compared to the background population. So that was not likely the explanation. So how about the rituximab patients ending up in the COVID cohort then? Are they older? Are they more disabled? Well, actually, they are still younger than all the rituximab treated in the registry. They have the same proportion of being progressive. They are rather less disabled than the others. So it doesn't seem to be an effect of the classic risk factors for having a severe expression of COVID-19. And there we are, and we can't do too much more than this. So it seems then, to summarize, that there are somewhat more rituximab treated patients among those reported. The Swedish situation is very peculiar. and therefore we need to go globally in order to have support for this. This is still, I would like to emphasize, descriptive. We have not attempted formal significance testing yet because the numbers are small and there are plenty of potential biases here. Could be an ascertainment bias with those on rituximab being more prone to get in contact with their doctors and nurses. Could be that the different treatment regimes in different parts of the country could affect this. And Stockholm is a hotspot of COVID in the country, and we have more rituximab patients in Stockholm. So this could influence, but it doesn't really seem to explain it all. So no conclusion possible here, but these findings to us warrant pooling with our data sources. So we'd love to do this within the MS COVID-19 collaboration, but we need other data sources to contribute to that pooling, because otherwise we will be left here without really knowing. We need larger numbers in order to be able to perform formal significance testing. But this shows maybe that in a setting where you can compare to the background population, you are able to seek some kind of a pattern out of data that otherwise may be a bit too loose in order to analyze. So I'll stop there, I think. Thank you.
Thank you, Jan. It is indeed quite interesting. And I think this is a question many people are asking about, what's happening in patients treated with rituximab. So certainly more data. We have a question here, so I'm going to go ahead. This is a question from Asia Wallach. Are progressive patient SPMS and PPMS?
Sorry, I didn't quite get you. It was a disturbance there. Could you repeat, please?
So in the Swedish cohort, are patient progressive SPMS and PPMS together?
No, yes. I mean, we analyze them separately, of course. I pooled them in this representation here. So here they are pooled, but they are, of course, possible to identify in a separated way.
And is there any information on time of treatment with rituximab? This is a question from
I mean, these results emerged in the morning of today, so I haven't yet done that, but I would expect numbers to be too few to know about this yet. But certainly we will see what we can find. But I don't think we should dig too deeply into the details yet. I mean, this is a very early observation. Numbers are small. We need confirmation. We need, in particular, other patient groups with anti-CD20 treatment. So I would emphasize that this is an illustration of what you might experience, but whether this is significant or not, we're far from being there yet.
Yes, of course. Jeff Correndo had a more general question. He was asking whether in Sweden, rituximab was administered in infusion centers exclusively.
Yes, but in a pretty large number of centers. So I think most MS centers, and there are like 60 of them in a small country, so they all give rituximab.
Okay. Well, thank you very much. I'm going to ask you to stop your screen sharing.
So.
Thank you. Oh, Jeff was asking, I mean, as opposed to at home in terms of the infusion. Sorry, we cannot ask you, Jan. We can't hear you, sorry.
Sorry. No, always in centers, never at home.
Okay. And there was another question, since we have you here. Is there any updates on outcome of ICU patients?
So far, everyone survived. We have one death, but that was a person who never entered an ICU.
Okay. Thank you very much. Our next speaker is Céline Louapre from France. And Céline, are you here?
Yes, I am.
Yes.
Okay, I'm going to share the screen. Okay, can you see it?
Yes.
Okay, so I am going to update the results of the French COVID cohort. So this is a work that is being submitted for publication now. So we have in France a registry of 280 MS patients. It has increased a little bit since the last extraction, and 7 NMO patients. So you have in this table the characteristic of the cohort. The mean age was around 43 years old for the MS population, 32 for the NMO patients. You have most of the patients that were on relapsing remitting course with a median EDSS of 2, 3 for NMO patients. And we have in the registry, we collected the comorbid conditions. And most of the patients were tested, but not all of them, of course, because especially at the beginning of the pandemic, the testing were not available, except for very severe cases. Some of the patients had a negative PCR for several reasons, mainly because they had a late PCR testing. But for those who were negative, that we reviewed the cases, and the patients had either positive thoracic scan, or they have a history with other relative people infected, for example. So what we have observed in that cohort, so this is a graph that is showing the severity of the COVID-19. So we used an ordinal scale from 1 to 7 for the severity of the COVID. And so you can see that most of the patients were not hospitalized for the COVID, but among those patients, we had 60 patients that were either hospitalized in not requiring oxygen or requiring oxygen, or even more severe cases with ICU or hospitalization. And we had 9 patients who died from COVID-19 in our cohort. And here you have a color chart with the treatments of the patients. And this is another representation of the severity score, but grouped by treatment. So here you have the untreated patients, 40 untreated patients. And for each treatment, you have the number of patients and the severity. It's in this color bar, and it refers to this severity scale. So we have performed logistic regression analysis to identify the factors that are associated with the severity of COVID-19. And so our outcome was the fact of being either hospitalized or dead from COVID-19. So a clinical score that is for the severity of COVID-19, which is over 3. And so here on the left, you have the results of the univariate logistic regression, and these are the odds ratio. So on the right, it's higher risk of being either hospitalized or dead from COVID-19, and on the left, this is lower risk. But this is univariate identification of factors, and then we run a multivariate regression model. And we present here the variables, the only variables that were retained in the model, which were age, which was associated with an increased risk of severe COVID-19, obesity, and EDSS. But the treatments, the DMTs in our population with that number of patients was not retained as an increasing risk factor for COVID-19 severity. And that's all.
Thank you, Celine. We are going, at the moment, I can't see any questions yet. So we're going to go, and questions usually appear a bit later on. So thank you very much.
You're welcome.
Speaker is Amber Salter, who's presenting from the National MS Society in the US Registry called COVIS. Amber, are you here? Yes.
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 And can you see my screen?
Yes. Thank you.
Okay, so I will say that we are still actively collecting cases. So this is just a snapshot of this morning of the registry data. And this is a North American data collection effort. So I think basically in the general, we have almost 200 cases that have been reported in the registry as of today. About 75% are female, and about a quarter are male. We have a majority that are obviously confirmed MS cases with a few NMO and MOG antibody disorders. The mean age is about 50, 49 in the registry, and we have almost 3/4 of the population of the reported cases are white, with another almost 20% for being African American. And we do have about 12% that are Hispanic or Latino that have been reported. So the majority, like the others, are RRMS, clinical type, and we do have some progressive MS cases as well, almost about 20%. The majority, 85%, are taking a disease-modifying therapy, and the majority are also confirmed or laboratory positive cases. We do have 10 deaths that have been reported in the registry. So that is what's on this slide. So here we have a comparison, just no statistics, just primarily descriptive on some of the different demographic and clinical characteristics of the deceased reported cases compared to those that were reported alive or recovering. And let's see if we walk through this, we can see that the majority of the deceased participants are male, that they are older, they're all white. There are 2 Hispanic or Latino that are deceased. The disease duration is longer for those that have been deceased, and you can see the majority of our secondary progressive. And we aren't collecting EDSS, but we do have ambulatory status, so the majority of these were non-ambulatory, and most had a comorbidity. Here we have the DMT use across the deaths, and you can see it's kind of, there's nothing, no real, I think, things that pop out other than 4 of them were not on a DMT at the time of their death. And then I did a little extra just on the comorbidities. So the majority of the comorbidities that the deceased participants had was hypertension. And you can see we had some other reported. The other comorbidities are listed at the bottom, just single incidents of those. We had 3 with diabetes and 3 with other cardiovascular disease. You can see that most, I guess only 2 of the 10 that are deceased had no comorbidities, and they went up to 5, having 5 comorbidities within some of the people that are deceased. And that's it.
Thank you very much, Amber.
Thank you.
Is there any questions for Amber? No, not yet. So our next and last speaker is Lauren Krupp, and she's going to present the data that they have collected in New York. Just before she set up her talk, there is a question about the 57 patients that was diagnosed with COVID-19, which is 33% of the case. How many of US patients are on ocrelizumab?
So I don't actually have that data. That's probably one of the limitations, I think, of one specifically this data set, but maybe even a little bit in the US. So I think we might have to rely on some of our other colleagues to come up with some, have some a little bit better denominators and to look at that.
Thank you. Thank you very much. Is Lauren there on the call? I think she is.
Yeah, I'm here.
Hello, Lauren, how are you?
Okay, now I sent you the slides. Otherwise, I could just share my screen.
Yeah, would you please share your screen, because I see you send, but my internet is playing up, and
Okay.
I cannot load them up on my computer. I have them on my iPhone, not on my computer.
Okay, can you see my screen now?
Not yet.
Okay.
Did you click the green share screen button?
I did. Let's
And
try.
you have to select, you probably have many screens open.
So I clicked the share screen.
Yeah. And then you have
And
a window with, yes, you have started.
okay.
Yeah, you probably have many screens open. So you
Yep.
have to stop sharing your internet browsers, but select your presentation, which I think is the first one, is it?
Right. Okay, so let's do that.
Yes, I think.
Okay, how about now?
Yes.
No?
Yes,
See it?
and you can you give us the view full screen, or? Otherwise, it's fine.
So basically, I'm just going to describe the first 76 patients and that we saw. And we had only 37 who were tested, but as you can see, there was really no difference between the patients who were tested and were positive versus the ones who never got tested. In terms of shortness of breath, coughing, or things like loss of appetite and GI symptoms. We had, of the patients, 18 out of the 76 were hospitalized, and similar to what other people are describing, the hospitalized patients were a little bit older. They were less likely to have relapsing MS. They were more likely to have comorbidities, and for us, the big one was obesity, and to a lesser degree, coronary artery disease. And we didn't see any big signal in terms of those who passed away or were hospitalized with respect to anti-CD20 therapies or the S1P inhibitors or any of the disease-modifying therapies. Similar percentages in each group, more or less, recovered or were hospitalized. The only thing I would say that is similar to what's been mentioned before is that about a third of our MS patients are on anti-CD20 therapies, and among those who were identified with COVID-19, closer to 50% were on anti-CD20 therapies, but they may be in contact with us more often. In terms of the patients with poor outcomes, deceased or ICU admissions, again, a number of them, 3 of them were on, of the patients, there were many who were on no disease-modifying therapy. One was on glatiramer acetate, one on natalizumab, and the others were on anti-CD therapy, and almost every one had a comorbidity. A couple got out of the ICU, but many passed away. One patient passed away before even getting to the hospital. One went home to a rehab facility. One went to a rehab facility, the other remains hospitalized, and the others are deceased. I've mentioned before, we have, out of 9 pediatric onset patients, 2 patients who had very severe courses. Neither required ventilation, but they did require oxygenation. They were hospitalized, and both were on anti-CD20 therapy. One of them was 17 years of age, and the other one was 19 years of age, pretty young for having such a rough course. But then again, there are these rare individuals who have a difficult time and are young. The overall, I think our experience is very preliminary. We will be adding all these cases to the registry that is being organized by the National MS Society that you just heard about. And we just are getting that through our IRB, so we can put this data into a larger system. Thank you.
Thank you, Lauren. We had a question from David to Jan. David was asking, in Sweden, has the policy been to continue treatment or to delay infusions?
So we are divided on that issue. I would say that half the MS specialists are delaying treatments, which is readily doable, of course, because the effect of infusions is usually much longer than the 6 months that we usually have as an interval. But there are the other half claims or isn't convinced that this should be any problem yet. But none of us have actually seen the data I showed because they are very fresh. So we have a discussion in a few days, and we'll see whether people reconsider this. But we're really divided, I must say. It was interesting to see that possibly there was this similar signal in the data that Lauren just showed, I think.
Lauren, you want to comment on that?
Yeah, we do notice a higher proportion of our patients with COVID seem to be on anti-CD20 therapies. It doesn't seem to, in our small numbers, give a strong signal for a more problematic course. I am troubled by those 2 younger patients because I don't really understand why a 17 and 19-year-old otherwise well would be in the hospital for a prolonged period of time, other than being on an anti-CD20. But that's not very scientific, so I don't know. Does appear like there may be a signal for increased susceptibility to the infection, but we're not sure.
It's pretty similar to what we have. It'd be nicer to have a dose response sort of relationship, but we don't have that either. So it appears to be, if there is something, susceptibility issue rather than a severity thing. Preliminarily.
Yes. Thank you. So David had another question about CD20. Well, it is a therapy used in other autoimmune diseases. like in rheumatoid arthritis. Does anyone know if there's any data from those autoimmune diseases? David, do you want to comment on your questions?
No, it's just that I haven't seen any. I mean, I have been looking. I mean, you know, it doesn't seem that in arthritis that there are that many reports of anything surfacing yet. And possibly there was a report that may be relevant this morning in MSARDs based on a study in Iran, where they implied that actually there was a higher incidence of COVID in the CD20. And I think if looking at the data, most of their patients were on rituximab. So maybe there is something there. I mean, it's quite interesting of all the drugs we hear. I mean, it may be because ocrelizumab is very common, but you've certainly heard a lot more cases of, you know, on this website, for example, of anti-CD20 cases than any other agent. So maybe there's something interesting there.
It seems to me that the rheumatoid community is not as vigilant as the MS community is.
Well, I think it's to you guys have to be congratulated for actually getting this off the ground and actually you know, doing this, because it actually really is informing, and I think it's really helpful to all the patients to get a feeling of what's going on, because it's obviously they're very worried, and yeah, I think that the good thing is that most people are actually coming through, whether it's they're getting the disease, but most people are surviving at the moment. So I think that's the positive thing I'm taking from that.
Okay. Thank you, David, to promote us so nicely, and this is recorded, so definitely we're posting it on our website. Is there any other questions from anyone? I can't see anything else. I think it was very good. Definitely interesting to look at the CD20 in other autoimmune disease, but continuing to get more numbers on MS cases. So if there's no more questions.
Oh, I think yes. Maybe one point I would just, it would be really good to make sure that for people who are in the registry, just to try and ensure to check that people do seroconvert, because obviously that's the big, one of the questions. One question is obviously whether people make antibody responses, and then the other question is whether they seroconvert later, you know. Because if it is it's good to know if there's going to be a blunting, because obviously down the line we're obviously thinking about vaccines as well, and so that's obviously one question that is on a lot of people's minds anyway.
Yeah, I do agree. I think we haven't seen a lot of data on it yet, but it's probably coming soon. Yeah. So I would agree.
Yeah, I mean, just to give you an example, I mean, I'm sure I've been, when I first started looking at this, there was 300 papers. Now there are 10.5, I think it was 10.5 to 11,000 this morning. They're coming in at 500 a day. So it's unbelievable.
Yes. Well, thank you, David. Thank you to all our speakers, Yannick, Lauren, Céline, and Amber. Thank you to all of you. We have one more question. Any comments on the CV cases in untreated MS? No comment from Lauren?
I mean, I think a lot of the patients who got infected and got ill, who are on no treatment, I think not all, but many of them had, in our group, had comorbidities and were older.
Agent comorbidities. Okay, well, thank you very much to all our speakers and to all the attendees for this call, and hopefully we'll see you soon. So thank you.